Hi, folks. My name is Victoria, and I use she, her pronouns. I'm so happy to be here today. I'm really excited to present. So today I'll be making a case for enhanced surveillance of HIV, which was an outcome of my practicum project at the BC Centre for Disease Control. First, I'd like to extend my gratitude to the generations of Indigenous peoples who have cared for and nurtured the lands, air, and waters of Turtle Island for all time. I acknowledge the unceded and ancestral territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations, where I completed part of my placement in Vancouver at the BC CDC. Today, I am presenting from my home in my yellow room in Ottawa on the unceded and continually occupied territories of the Anishinaabe Algonquin Nation. So to situate myself, I am a queer, brown, very loud, and neurodivergent person, descended from South Asian immigrants and refugees who settled decades ago in what is colonially known as Ontario. My positionality impacts how I approach this project. My lens is shaped by my career in science policy and data analysis, my experiences with community and union organizing, and my personal politics of justice and liberation. It was really important for me to take a critical approach while examining how HIV risk is produced and defined by our health systems. HIV targets the body's immune system and weakens its ability to fight off infections. It can pass from one person to another through sexual and non-sexual activities that come into contact with blood or body fluids containing the virus. Transmission can be prevented by using a condom during sexual contact, by not sharing drug equipment, taking HIV prevention medication, and regularly testing. HIV is treatable with antiretroviral therapy, which prevents the disease from progressing further or being transmitted to others. Without treatment, HIV gradually weakens a person's immune system and can progress into AIDS, an advanced stage where people become more susceptible to fatal infections or cancers. HIV disproportionately impacts sex workers, gay, bisexual, and queer men, people who inject drugs, transgender people, and people in prisons. 42 million people have died from HIV and AIDS globally. First named the, quote, gay-related immune deficiency in 1981, AIDS was a devastating epidemic fueled by widespread homophobia and government neglect. In the absence of public health, gay and lesbian communities provided safe sex education and hospice care for people dying from AIDS. In the late 1980s, people living with HIV used civil disobedience and direct action protest to demand funding for treatment research. The medical advances that we have for HIV today are the direct result of decades of their social activism. The photos on the left-hand side here show protests in the 1980s and 90s in Canada from archival footage collected by the AIDS Activist History Project. They have an online collection. I highly recommend you check it out. So today, HIV cases have been steadily declining since the early 2000s as global responses to the AIDS epidemic ramped up. The 2025 UN AIDS testing and treatment targets set thresholds where 95% of people living with HIV would know their status. 95% of people who are diagnosed would receive antiretroviral therapy, and 95% of people who are treated achieve viral suppression. However, recent public health data shows that progress is stalling in low incidence settings. In 2022 and 2023, the United States, Canada, and 21 countries in Europe reported increases in new diagnoses of HIV. Researchers currently theorize that this may be the result of rebounding HIV testing after the COVID-19 pandemic. The graph on the bottom left shows new HIV diagnoses in BC that are trending upwards in 2023 and 2024, which was the impetus for my Culminating project. In Canada, provincial and territorial health authorities collect data on HIV and AIDS for public health reporting. Public health surveillance, which you can see on the cycle on the left, begins with data collection and analysis, followed by information dissemination, public health action, and evaluation. Routine public health surveillance can answer questions like, how many cases are there? When and where are they occurring? And sometimes about who is impacted. However, the system is not well equipped to identify how or why a disease is spreading. The purpose of my project was to identify underlying factors that may be leading to recent increases of HIV in BC. My objective was to gather information not typically included in the provincial surveillance system using qualitative and quantitative methods to support my project outcomes. For the qualitative methods, I met with 15 organizations that provide frontline health services for HIV across BC. This group included public health partners, clinical and community-based representatives, and people living with HIV. Strengths of this approach were that it was grounded in people's lived experiences, and we got to tailor the discussions to reflect organizations' varied perspectives. Unfortunately, we were somewhat limited by scheduling constraints and weren't able to meet with some organizations in Fraser, which limited our regional distribution. Information gathered from these meetings showed interesting regional differences in HIV care across the province. We heard about months-long delays in accessing HIV prevention, inadequate testing capacity, and discrimination or misinformation from primary care providers. Folks noted that Sorry, my cat is coming in. Folks noted that recently more people seeking HIV testing and treatment were recent immigrants without health insurance, were smoking meth, were heterosexual people, or were older adults. Oh, hello. Sorry, everyone, for the butthole. Were older adults with advanced HIV infection. They also shared theories that new HIV cases may be delayed diagnoses due to the COVID-19 pandemic. Okay, Minerva, you need to go. Goodbye. For the quantitative methods, I used descriptive and inferential statistics to analyze all HIV cases reported in BC from 2014 to 2024. Strengths of this approach were that variable selection was informed by the earlier qualitative methods, and my data quality recommendations came from direct experience with the limitations of the system. However, my analysis was limited to known or previously measured variables. Interestingly, these results echoed findings from the consultation and engagement meetings. Unfortunately, I can't share the detailed findings due to data confidentiality at BCCC, but I can provide a high-level overview. So for the first time in 2024, the largest proportion of HIV cases was reported by people living in the Fraser Regional Health Authority. Other increasing trends showed people traveling to a different testing region to access HIV testing, engaging in sex with people of different genders, and sharing their drug smoking equipment. In the regression analysis, I compared reported HIV diagnoses in 2023 and 2024 to the previous 9-year period of the dataset. I found that people were statistically significantly more likely to identify as non-binary, transgender, or other genders, be sexual partners with people of different genders, live in the Fraser Regional Health Authority, or have established HIV infection at the time of testing. My project's findings have important implications for public health. First, barriers and facilitators to HIV testing, prevention, and treatment in BC exist at a health system level and therefore require systemic solutions. Second, frontline observations can function as an early warning system for changing disease patterns, and local assessments play a vital role in understanding regional epidemics. And third, affirming HIV services should be safe, accessible, and sustainably funded across BC. To conclude, public health surveillance must be enhanced and diversified to better understand the context in which HIV transmission occurs. Investing in community-based surveillance can provide essential perspectives that are missing from traditional data systems. Risk assessments and behavioral interventions tend to focus on individual practices and ignore how risk is produced by structural conditions like systemic oppression, poverty, housing inequality, or immigration status. We can expand our focus by moving towards a social model that looks at, for example, how desire and pleasure inform social and sexual practices. This process involves repositioning people with lived experiences at the center of HIV care and partnering with frontline health organizations to understand how to better serve these communities. Historically, urgency has been an effective mobilizing tool in the fight against HIV and AIDS, but it can't be our only tool. Question remains, where do we go from here? And that's it. Thank you. I'd like to thank Dr. Sylvia Bartlett. Thank you for coming. And I saw some folks from the rest of the CPS epidemiology team. Oh, sorry, I hit my mouse. Thank you for coming. Thank you for trusting me with this really important work. And thank you to Mira and my friends in the MPH cohort for the support. And I also want to give a shout out to the organizations listed here who participated in the consultation and engagement meetings. They met me with so much curiosity and compassion and honesty, and it was such incredible, rewarding work with them, and I will never, ever forget it. So yeah, thank you.